Good afternoon to those of you just joining. If you're in the UK, good morning. If you're joining from elsewhere and it's the morning, we are delighted to welcome you to this afternoon's Queerness and Access to Healthcare webinar as part of our Queer Living webinar series. We've loved bringing this series to you. We've covered polyamory, bodily autonomy, finance and mental health, and today we are covering queerness and access to healthcare. Just to introduce myself, my name is Neil. My pronouns are he, him. I am the events manager for We Create Space. I'm based in London. For those that need a visual description, I have blonde spiky hair, big thick glasses, and a pink top. I've got stubble and piercing in my lip and my nose. Yeah, that's me. Great to see your intros coming through. Please take a moment to introduce yourself in the chat box. We'd love to get to know who our audience are. Share your name, your pronouns, what you do, where you're joining us from. We love to see those. Just to take you through how today is going to work, we're just doing an intro now. We'll have an in conversation with our fantastic guest speakers, Coda and Eva, two of our wonderful members of the We Create Space collective. We'll then throw it open to audience Q&A. We'd love to hear your questions. We've factored in time for them. Who are We Create Space? For those of you that haven't heard from us, I have a short video to share with you.
Hi, my name is Michael, and I'm the founder of We Create Space. We Create Space has evolved into this global community, movement, and learning platform with now over 30,000 international members. Our DEI consultancy services more than 180 corporate clients, and we've trained over 100,000 employees on topics relating to diversity, equity, and inclusion. Our growing collective of over 300 speakers support our mission of improving the lives of LGBTQ+ people and other underrepresented groups of professionals around the world. And as a social enterprise, we continuously invest our profits back into the communities we serve. We connect thousands of LGBTQ+ people and allies with free tools, knowledge, and a support network for personal growth, leadership development, allyship, and self-care. We do that through events, experiences, content and research, resources, and consultative work. So whether in a corporate environment, on our online learning platform, or in a community setting, we aim to create space for learning, connection, and growth. Join us as we build a brighter, more inclusive, and sustainable queer future.
We absolutely love what we do, and that is creating spaces for people to learn, connect, and grow. You heard more about what we did just there. But in order to do the stuff that we do in the community, as a community interest company, for our corporate bookings, that funds all of our community events. So we cannot do our community events like this one, like the Queer Speed Networking, Queer Women in Business, all of those events. We can't do them without our corporate bookings. So if you can bring us into your workplace, we would love to hear from you. Get in touch, whether that is through events and experiences, workshops, webinars, panel discussions, you name it, we can do it. So please do get in touch. Here's a bit of our overview of our Queer Living series. So today we're focusing on access to healthcare with a view of with a lens of queerness and specifically transness. And then in a couple of weeks, we will be focusing on employment and careers. Here's just a little bit of group agreement before we start. I shouldn't need to remind you, but just please be open and respectful during the session. We've factored in time for questions, as I've said, but please ensure that those are centered in kindness. Some of the topics and issues we cover today may be challenging or triggering, and we'd love you to take care of yourself whilst listening to and engaging in today's session. It is being recorded, and so you can dip back into it at any other time. I'll be in the chat box, and I'll be kind of like popping links in there and letting you know what's going on throughout the session. But I'd like our two speakers to join me on screen, and I'm going to hand over to my wonderful colleague Coda, who's going to set the scene for this session before our conversation with our guest speaker Eva. So Coda, over to you.
Hi, everyone. It's really nice to be here. Thank you very much, Neil. I to give a very brief overview of how we're talking about healthcare here. Healthcare can be a highly contentious subject when it comes to the experiences of people from underrepresented groups. Many of us have faced and continue facing difficulties around providers who are lacking the knowledge about our needs, and we encounter some levels of discrimination from insurers and providers. We encounter things like delayed or foregone care because of concerns around how we're going to be treated. In the absence of concrete legislation prohibiting healthcare discrimination based on sexual orientation and gender identity, queer people are often led with little recourse when discrimination occurs. And this is the kind of rough context that we're going to be having this session in. I'd love to bring Eva in to introduce yourself a little bit, and I'm happy to give an introduction after that as well.
Thanks, Coda. I'm really glad to be here. Hi, everyone. My name's Eva. My pronouns are she, they. As well as being part of the We Create Space Collective, I'm also Director of Innovation at Birmingham Pride, Events Manager at Trans in the City. I'm also Ambassador for two charities, Diversity Role Models and Queer Britain.
Thank you. And my name's Coda. I'm here in my capacity as a DEI consultant of a couple of years, as well as a client relationships manager at We Create Space, where I deal with all things clients. I'm also the co-founder of Trans Voices, the UK's first professional music organization, creating opportunities for performers in the music industry of queer and trans experiences. And yeah, I'm bringing a lot of my personal experiences as someone who's had to navigate our healthcare system and like possibly a global trans healthcare system to this conversation. So our first topic, and we're going to jump straight into it. What is the difference between being a trans patient versus simply being perceived as a patient? Eva, I'd love to bring you into this, and I would love I'll throw a phrase at you. What does trans broken arm syndrome?
That classic. It started within like the psychotherapy, mental health services side of things. But it quickly expanded to all areas of healthcare, especially for trans people. Basically, it's where a clinician or physician can focus more on an individual's gender identity than the actual problem at hand. So, someone could go in presenting with literally a broken arm or a broken leg, and they have more interest in your gender identity. And that leads that kind of misconception, that the unconscious bias, it leads them to think that everything is linked to your transness, that you have a broken arm because of your transness. For me personally, I've had a number of encounters with my doctor about this. I tried to go for an assessment for autism, and I was basically told, you don't need it, you're trans, focus on being trans, you don't need another label. I asked him for a referral to something else, and he basically said that no, it's because you're on so much medication that you probably shouldn't be on anyway. It's not medication designed for you. Therefore, that's what's causing the problem. And when I said that this issue actually arose way before I started to medically transition, he pretty much just doubled down on that, saying, you're taking medication, there's going to be risks, refused to even listen to the problem. And everything was basically because I'm trans. All the issues that you're facing are because you're trans. It's because of the medication. It's because of this, that, and the other. And at the end of the day, our needs aren't being listened to. Being a patient, being a trans patient. I'm sure you can attest to this, that before medically transitioning, you have a certain relationship with the healthcare system, especially with a GP. The moment you transition or start transitioning, your relationship with healthcare is very different, even right down to how receptionists and GPs talk to you. And it's shocking that it happens, but it really does.
Yeah, so much of what you're saying resonates, and I think the feelings that it brings about in me are it's a real sense of disengagement and a real lack of trust. And I know that about myself, and I know that about many people in our community and in the broader queer community who avoid accessing general care because they know that they're going to be treated differently, and they know that things are going to be tied to their identity, which are completely irrelevant. And there's like the kind of personal self-imposed barriers that we have to overcome to access the care that we deserve can sometimes feel really quite insurmountable. I think,
Absolutely.
especially from a mental health perspective, I know the feeling of to struggling to believe that my GP would care much about what I have to say when I'm going through transition, when I'm going through a fairly kind of surgically involved transition as well. And this idea that everything is going to be caught under the kind of catch-all umbrella of it's because you're trans, it's because you're queer. I remember getting elements of that before my transition, when kind of living as an out and about queer person, but things really took a turn, right, when after transition. And to add on to that, the feeling that so many GPs kind of share this sense that they're not comfortable treating trans patients, that they don't know what's going on. There's a serious level of resistance around prescribing hormones and things like that, which we can get into in the next section. But I think that level of, oh, I don't want to engage with these people, it really quickly trickles into our general relationship with the healthcare system.
Yeah, absolutely. And I think that has a real knock-on effect within the community, because it's not just, gender affirming care we're trying to access, it's any care. And when you have that relationship which is essentially broken down with your healthcare professional, then you have zero confidence. And Transactual previously did a survey and found that a really high percentage didn't even bother going to a GP because they feared being misgendered. They feared, being judged. And that fear comes from a real place. And that fear usually is because they've experienced it, whether it's through microaggressions or direct discrimination. They have every reason to have that fear.
Yeah, I again really resonates, and I think something really worth bringing into this is the intersectional experiences of people who can be disabled, or people of color, people who are immigrants. I know for myself, something big that I have to deal with is that kind of administratively, I live a separate life compared to kind of who I am on a day-to-day basis based on my name. And even the idea of getting prescriptions under my dead name in a pharmacy, engaging with my GP under my dead name, kind of explaining, going through this entire charade of what my situation is, how we've gotten this far, why it is the way that it is. It can be really tricky, and it's this labor and this weight that gets added onto us, right? Which prevents us from engaging with life. Because I think what's most particularly interesting here to mention is that what this informs and what this feeds into isn't just a resistance to engage with the healthcare system, but more broadly, a resistance to engage with and a barrier to engaging with life as it should be, and like within mainstream spaces.
Absolutely.
Yeah, in this sense that like that you're pushed out of a mainstream space like primary care, I think can have a real knock-on effect on people's confidence about where they belong. Otherwise.
Yeah. I mean, at the end of the day, healthcare is a human right. We are all entitled to it. And to have that, level of gatekeeping, and it's not just, for queer people, it's almost like there's a hierarchy. For cishet people, you go to the GP if you want help with fertility treatment, fine, they'll give you the info you need, they can make the necessary referrals and give you the advice. If you are lesbian or gay, for example, and you wanted to talk about fertility treatments or accessing help, you may get some sort of resistance. You may get professionals that are quite helpful and have done their homework, and you can kind of get a certain way. if you are trans and gay or lesbian, for example, or bisexual, you've got zero chance. I mean, when you medically transition, a lot of them don't even talk to you about gamete storage or anything like that, let alone further down the line what your options are. So it's almost like the more marginalized you are, the worse it gets.
Yeah. And thank you for mentioning this topic, because you touched on medical gatekeeping, and that's actually our next topic of conversation. I would love to hear your thoughts on how the system, like where does this start for so many practitioners? Like what do provisions in the curriculum look like? How does like education within medical curriculums impact the state of trans healthcare and queer healthcare, and where do those gaps start forming first?
A lot of the time, the gaps start from right at the beginning, a health professional's educational experience. I've worked with a number of universities. I've worked with King's College London quite a bit. And when speaking to second year med students who was just starting their placement, going out into GPs and working with the public, they all say the same thing. They hardly know anything about trans healthcare. In fact, the whole curriculum only touches briefly on it, maybe 15 minutes worth. And if there's no information, there's no actual education at that stage, then when they graduate, when they become qualified practitioners, they're certainly not going to have the time then to go out and research, educate themselves. The GMC and the BMA both have information about this on their websites, but again, you try telling a doctor, go and read up about trans healthcare and what we're entitled to. For example, if somebody is self-medicating and they ask their GP to be, put onto bridging hormones or something, then there is guidance that says, yes, for the safety of that person, you need to take them off that self-medication and put them on a bridging prescription because it's for their safety. But still, despite the guidance being there for the practitioners, they still refuse.
Is there something as well there which I was reading about over the last couple of days, specifically around what falls under a GP's kind of necessary required responsibilities, and what falls within, oh, you might not have much information about this, so you're not required to look at this. Or if you have a special interest in this area, then you can, you expressly, you need to be very comfortable as a GP to be able to do this. And the moment you're not comfortable as a GP, it's you can deny care, essentially.
Yeah, exactly. And under guidance, if you have a GP that's not willing to prescribe, for example, you are entitled to seek a second opinion from another GP. And there is guidance, and the guidance says that a GP should ask for further guidance themselves if they are not competent enough. I can tell you now, a GP is not going to want to put their hands up and voluntarily say, actually, I'm not competent to do this. And a lot of the time they will just say no, that a lot of the time they'll make excuses, they'll continue that gatekeeping, they will blame somebody else. And it's always to the detriment of us as a community. And it's shocking that it happens, but it really, really does. And we're now seeing GPs saying that they personally, their own personal beliefs, they don't believe that we should be doing this as trans people, and therefore they will refuse to prescribe. So when you've got things like personal beliefs coming into this, then it becomes a really, really dangerous area, because that's not what they signed up for. If we look at, for example, a Jehovah's Witness who, for their own beliefs, will and can refuse a blood transfusion because it's part of who they are. So as a patient, they can refuse that even if they know that their life is on the line and they will die without the transfusion. Let's switch it around. What if it's the doctor, the medical professional treating you, that has that belief? Who are they to say that because of my belief, what my religion, I am not going to give this patient a blood transfusion? And that's why we've really got to boil it down to, whose belief is getting in the way here? And at the end of the day, health professionals are there to treat everyone regardless of what they think. The guidelines are there, everything is there. And, there are, things that are against the law, that's fine. But if there is guidance there, then there's no actual reason for them to refuse.
Yeah. Thank you. And I think something interesting that you touched on, which was a recent survey done by a private medical healthcare provider. I'm not going to name them, no free promo, but something that they shared was that out of a couple of hundred people who were denied care from their GP around kind of hormones and prescriptions, 1/4 of them were people who had been had been through the NHS gender clinics.
Mm,
So they were people who had gone through the most formal possible routes and were still denied at the GP level. And this normally happens once someone has been with the clinic for a couple of, usually between at least 6 months to 9 months to a couple of years, until their hormone levels stabilize. And that's the moment that they are signed off back to their GP's care, back into their GP's care. So to see that level of belief being able to kind of control like who gets
mm.
what is feels quite staggering, doesn't it?
Yeah, it's power at the end of the day. It's it like you said, they've been signed off by a specialist service, and it's back to the GP care. They've been discharged from a gender clinic, back to the GP. And I hate to say it, and I don't want to like trivialize their job, but in this case, all they have to do is authorize a prescription. That's it. They're not asked to intervene, to consult, to give their opinion, or to re-diagnose. It's already been done. All they have to do is just reauthorize a repeat prescription. That's all. But still, there is an element of them needing to almost control the narrative at their end.
I think what's really interesting here, and a topic that we touch on, is bodily autonomy.
Mm,
And the sense that as trans people, as very openly queer people, we can have our bodily autonomy taken away from us quite easily on a healthcare level. And I know that that's a fear that a lot of us live with as well, that sooner or later our bodily autonomy, be it by an untrusting GP or be it by some other possibly even non-healthcare related administrative process, our autonomy is going to be taken away. Um,
mm,
and transition in itself, and I think openly living as yourself, the further you go as kind of deepening your kind of sense of understanding of an identity that is for all intents and purposes marginalized, that like the it's a journey, it's a pursuit of autonomy.
absolutely, yeah.
Um, and when a healthcare system, when a very, very strongly regimented, regulated healthcare system essentially tells you, no, you don't get this either now or you don't get this anymore. Um, what's the impact that that can have on a person? What does it feel like to navigate that sort of broken system?
It's excruciating. I mean, living with that fear constantly, you know, we all know it's a broken system. You don't have to be queer or even trans to know that. We hear it day in, day out. The NHS is broken. Great. But what are we going to do about it? And without answers and without being included in the solutions, without being heard, our mental health is scraping the floor every single day because decisions are made without us. We're being talked over. It's almost like everything's decided for us, and we're just expected to kind of lay down and say, okay, great. But this is our existence. We've existed, trans people have existed for centuries. And this issue with removing um, gender affirming care access
Mm.
is a recent thing. Trans people have been, in the 80s, trans people had access to gender affirming care. Where was this outcry back then? Puberty blockers have been used for decades by cis youths, not an issue. So why all of a sudden, when you insert the word trans into the sentence, there is suddenly a problem? The recent puberty blocker ban here in the UK, which was extended till November, that was only for trans youths. They are still able to be prescribed for cis youths. So when we look at it, when we break it down, it's not just a broken system, it's a discriminatory system. Because when we look at why one group is still allowed it and one group isn't, yet the reasons given for trans youth not being able to have access to them is because there isn't enough research that it's potentially harmful for bone development and fertility and things like that. Well, yeah, but then cis youths can and are on puberty blockers for a lot longer than trans youths. By the time trans youths even get through the system, and they've got a waiting time of about 4 to 5 years now, 4 to 5 years means you miss that vital window where puberty blockers will even work. So a lot of the time, they don't even get access to puberty blockers, yet there is still this ban. And it's so disproportionate. So when we look at a broken system, we have to look at not just why it's broken, but the agents within the system who are almost kind of using it to their advantage because of their own personal belief. And then when we look wider still, when it comes to things like bodily autonomy, we see that religion also has a very powerful kind of pull on things over, in the US, you only have to look at how religion plays a huge role there when it comes to subjects like abortion as well. So, it's a broken system, but then we need to be able to kind of put barriers in place to say, okay, where is it broken? And we have to look at it from a practical, pragmatic point of view. It's broken because of X, Y, Z. It's not broken because, a potential medication is harmful for one group. We have to look at it so that there is a solution for everybody. And that means trans people as well.
And when you talk about the practical and pragmatic, what comes to mind is private healthcare, not because it's practical and pragmatic, but more so because it feels like a sort of band-aid to the system that we have at the moment. You have people like hormone prescribers who charge upward of 80, 90, 150 pounds a month, just for the privilege of having a subscription, let alone additionally for appointments of any kind to see any sort of practitioner. Often those sorts of systems aren't necessarily endorsed by GPs and by primary care providers. Additionally, you're looking at a lot of private care, a lot of private gender-affirming care, looking like including interventions that might be offered on the NHS, as well as those that aren't, because the NHS classifies very, very specific, fairly limited interventions as kind of like, quote unquote, I guess, necessary for a very kind of traditional sort of transition.
Absolutely. I mean, like at the moment, gender affirming care under the NHS, if you're trans feminine, looks like bottom surgery, laser hair removal, and hormones, and they're essentially boiling down what it is to be a woman to those three things.
And also, and even then, right? First of all, the laser hair provisions or any sort of like the majority of provisions aren't particularly sufficient. And also, and this is a very funny thing. I remember speaking to my family about my biological family about wanting gender affirming interventions on my face. And I was explaining to them like, well, I'm not going around the world, naked and in my with my genitalia out in front. Like that's not the most urgent thing that I needed at the time. It was something else. It was something that would have secured my personal safety and my personal sense of kind of contextual gender affirmation within the world. And that's something that is completely and wholly like unconnected, completely disconnected from the system that we have in place. And something like that in my personal experience, a lot of those, like pursuing the healthcare that I needed required a lot of personal sacrifice. And it required a sacrifice of time, a sacrifice of money, a sacrifice, or rather a reinvention of career, which happened twice for me. And that was such a challenging kind of undertaking to do in my like early to mid 20s, at a time when you would look at the world kind of more broadly around you, and you're like, nobody else seems to be going through this. Everybody else seems to be enjoying their money, spending their money, or pursuing a career that's not making a lot of money, but that they love, or
Mm.
is saving towards something really significant that's going to set them up for a very long-term um, prosperity. And there's a real sense of this feels unfair.
Mm.
This is not right. And even from the perspective, I can recognize even from the perspective that I'm speaking right now, that it's such a privilege to be able to save, to be able to put money away, and to be able to work towards a private transition. And that feels like such a challenging space to be in sometimes.
It really is. And, there's that phrase, living to work or working to live. Well, for us, we don't get a choice. We work to survive, and we survive through healthcare, because being trans is a visual thing. It's a lot of the time, it's not like where, you come out as gay or lesbian and you just have a spring in your step, you look a bit more fabulous, and you're more at peace with yourself. When you come out as trans, that's just the very first hurdle. You've got the physical, visual challenge, because every time you are outside of your house, you are challenging people. You're also putting yourself in danger just going from, home to work. And we end up going for jobs that we might not necessarily like, but it pays okay, or it has, it happens to have a specific trans healthcare benefit as well. And we put ourselves through that. And like you said, it does feel unfair. I've had to put, some personal savings into my private transition, because waiting on the NHS, I've been waiting for, well, since 2017 now, so 7 years, and it's not looking like it's I'm going to move anywhere on that waiting list anytime soon. And the mental health toll that that has on an individual, where you are literally left in limbo, is, you can't even begin to put that into words. And I guess we do have a right to feel it's unfair, because at the moment, trans healthcare in the UK on the NHS is the only area that has always been openly measured in years.
Mm.
And when we come out, it's almost like that euphoria rug has been pulled from under us, because all of a sudden you've been slapped with this letter in front of you from a gender clinic, who are there to help you, to say, we're completely outside of our 18-week referral to treatment target. There's nothing we can do about it. If it was any other area, there would be some sort of focus, but with us, we're not. And that drives us to private healthcare. But the more we move towards private healthcare, the more the state will then look at a community and think, well, we don't even need to, provide healthcare provisions under the NHS, because they're all going private, so we can just remove that completely.
Yeah. And that's such a huge issue, right? Where we're talking about the NHS seeing that people are falling away and not using the services, and they're saying, "Great, so we don't need to provide them. We don't need to think about this," and that's a real issue with the system. And I do feel that there are ways that our healthcare and the challenges that we face as trans people, as queer people in the system, can inform how things need to improve for everyone.
Mm.
Something immediate that came to mind while you were talking was around how GPs are encouraged to do further research. They're encouraged to seek further support when they're not certain about something. But at the same time, like we all know, GP workloads are so completely overwhelming. GPs are so overworked that that's not really something that I can so imagine myself in a position where I know that I don't have the capacity for this, and I know that for me to be able to do this, I need to take so much time that I would otherwise spend investing in helping other people.
Mm.
And I think it's really, to me, it feels curious to explore that perspective, while without necessarily taking responsibility away from people, and taking the accountability away from them either. But I'm curious to hear about how you feel the challenges that we face can make for a better system for everyone.
Yeah, I mean, going back to the broken system that we mentioned earlier, if we are to reform things, if we are to really build from the ground upwards and have the necessary foundations in place, there's a lot you can learn from trans healthcare. Um, the amount of gatekeeping we go through to make sure that we are making the correct decision, if you were to say to anybody else, they wouldn't believe you. For example, to even begin HRT, under the NHS system now, you wait for your first appointment, and then you eventually will be diagnosed by one psychotherapist or psychologist. You then have to be diagnosed by a second independent psychologist. They themselves will get their heads together, compare notes, decide if you are trans enough. In the meantime, you've had 12 months in between appointments. So that's on top of your waiting time for the first appointment. If they decide you're trans enough, you go on a second waiting list where you can wait anywhere up to 18 months for an endocrinologist. Then you start HRT. So from the start of when you are first referred to the start of treatment, a patient could be waiting 10, 14 years, to start HRT. The very same HRT that menopausal women, in the case of trans femmes, have access to. They don't have to go through that. If they present to their GP and say, I have these symptoms, a GP can pretty much start them on HRT almost there and then. They don't need to go to a specialist. But when we look wider at things like breast augmentation, for example, going private, at the moment, when from a trans point of view, I had to go and see a psychologist even before my surgeon would even give a consultation. I had to basically get a letter from a psychologist at my own cost to say that mentally I am capable of making the decision that I want boobs. That's it. I had to pay for that, and that was like 550 just for that letter. I
What
then
pri-
take I then take that to my surgeon. I go for the consultation, and then we move ahead. But that intervention to make sure I am mentally stable enough, if you like, to go through with that decision, maybe we should look at things like that for the wider, population, because we often hear a lot about, cosmetic surgeries gone horribly wrong. Injectables aren't really regulated. You can go on a course and set up your own business doing injectables, and sometimes there can be horrific results. So, having a bit more care and taking the time to ensure that patients are aware of what they're doing, they're mentally fit to be able to make this decision before they take that next step. So I think there needs to be a balance between having certain things in place to protect people, but nowhere near the extent that the trans community is facing right now.
Thank you. Thank you. I think it's such a valid point, especially around the people who seek and pursue surgery, where kind of issues like body dysmorphia can come up, and like looking and diving genuinely into those issues without the level of denigration that certain communities experience. But thank you for that. Neil, I'm wondering if it's time to bring you back to take some questions. I think it might be.
There we
I think.
go. I'm here. It is time for Q&A, and we've got some fantastic questions already coming through. So if you have a question for Coda and Eva, we would love you to hear it. We're factoring plenty of time for them, so do pop them in the Q&A box, and we will work our way through them. So my first question for you, and this is one from Saba actually. Saba asks, as a trans ally, what would you suggest we can do to support you in solidarity to help stop the ban on puberty blockers and get the law stopped from being passed?
Ooh, that's a good question. The first thing I would say is really like at the moment we're trying to be heard and we're not. The health secretary has refused to speak to trans organizations, parents of trans youths, but has met with healthcare professionals that are anti-trans, which go figure, So helping us to be heard is one thing, but sometimes even if you help us to be heard, you open that door, that doesn't guarantee that we'll be invited to step through. And in those cases, speak on our behalf and say, look, you are clearly not taking on board the opinions, the research, or everything to let's have this discussion. Let's look at why it's hypocrisy that you will prescribe for cis youths but not trans youths. Let's really challenge that, because until we can really get a definitive answer, And the answer is because we're transphobic. That's why we're not subscribing anymore. We're just getting kind of wishy-washes, real just excuses at the moment as to, oh, there's not enough research. Oh, well, it's not safe. Well, do something about it. If there's not enough research, you've had years to deal with it. You already have years of research from historically prescribing. So, let's cut to the chase. Let's really get to the nitty-gritty of it. And I think allies really have a place there where we aren't being invited to the table. Then yeah, call them out on our behalf and call them in as well to really have that conversation.
If there's one thing I also want to add to that, I think, and I think everything Eva is saying is absolutely spot on. If there's one thing as well, engaging with trans youth, including action groups like Trans Kids Deserve Better, could be quite useful. I think trans kids have an ongoing frustration about not being heard or being listened to by queer and trans adults, and as well as allies. So being able to amplify their voices when they are out there taking action is another really, really impactful way to make a difference.
That's it. Listen and educate. Education is a massive form of allyship, right? When it comes to kind of myth busting, and you've touched on the myth busting, and challenging anti-trans rhetoric, but also rhetoric around health, right? People assuming that things are one way. What reliable resources would you advise people to go to for those more solid and reliable understanding around some of the health issues?
I would recommend Transactual, who do a lot of research and they engage with the healthcare system directly. On their website, they have a wealth of information, surveys and studies that they've commissioned. They're all on there as well.
Fantastic. Coda, anything from yourself?
Nothing that immediately, nothing that I want to share immediately. I've just shared the Transactual website link in the chat.
Fantastic. Thank you so much. And we'll pop some resources over in the follow-up email for this, including Transactional. We have a question from Ruth. As a trans healthcare professional trying to educate my colleagues, what is one key thing you want hospital professionals to know, or a tip, in order to start breaking down barriers?
One thing I can start with very and it is not way particularly big. I think knowing that a trans person is always going to be afraid in a medical setting. A trans person is always going to come in a medical setting and be like, I am scared that I'm going to be 1, 2, 3, 4, 5, 6, 7. There's so many anxieties and so many barriers that someone has to overcome to access support. And if they're there kind of in an emergency setting in particular, and like they maybe haven't even had that chance to process all of that, it can be quite a shock. So I think having a bit of grace and having grace with people who and trying to treat people, just radically treating people as people, as humans. I think that comes to mind to me immediately.
Yeah, I echo that. No pun intended, but I echo that. Just we are people, at the end of the day, we present, especially, in an emergency situation, because it's life or death, it's an emergency. We've made a decision that, yes, on this occasion we will go and seek help. And when we do so, we're vulnerable, but the person you see before you, they're asking for your help. So treat them as an individual, be sensitive to their needs, but also don't think, don't think that, oh, I don't really agree with any of this, and you allow that to influence you. You've really got to check not just your own privilege, but any unconscious bias. You've really got to ask yourself, the actions, the decisions that I'm making, are they purely because the individual needs this treatment or needs this advice, or is that my own opinion? And I would say, look at them as a human first and foremost, and then move from there.
Absolutely. So it's down to dignity and compassion. It's not an opportunity to educate yourself or to spout your opinion. It's someone's in front of you. Absolutely. Thank you so much for sharing, and and I appreciate the vulnerability that comes with that. We have a question, anonymous question. Do you have any advice for navigating between NHS and private services? Even if we can afford to go private, we still need to go back and forth between different services, and it's exhausting explaining ourselves over and over again. I mean, very much a question beyond just being, just queerness and access to healthcare. But in your experiences, what have you encountered with that?
Every time I see a medical professional, I have to out myself. I recently went to my local hospital for, I mean, I've been there for a 12 months worth of appointments because of my asthma. And each time I see someone different, I've pretty much got to say, oh, by the way, you've got that wrong. That's not the right title. Or, when they ask questions like, are you pregnant? And you say, absolutely not. I probably shouldn't laugh when I give that answer to them. But you're basically saying, okay, this is me, this is what I'm presenting with. I'm trans. I've had to go for an MRI scan for the bottom of my spine, and I was so worried because, like, what else are they going to see, and things like that. So it's a really scary time for all of us. And I don't know, I think there needs to be a lot of compassion for the community to understand what we go through to even present at that door.
Mm.
One thing I'm not convinced that I have an answer at the moment. I feel like an answer might come to me by the end of what I'm going to say, but I can just say that this is a very common experience, and it's an experience that a lot of us have to go through, where we're kind of juggling the NHS and private care of some kind, to some extent. I've juggled like NHS care, private care in the UK, private care abroad, and my GP on top of all of it. And I think it's always exhausting, and it always feels, to call back from a word previously, ever so slightly denigrating, at least, if not much more. There's a level of, yeah, candor that I think a lot of us become quite clinical about how we talk about ourselves. We're like, yep, I'm a trans person. I have had this done. I've done these things, these things. This is something you should consider. This is something you should think about. But this has also happened. And it's a lot I think it takes a toll, I think, to be able to depersonalize so much. I mean, as trans people, one thing I know a lot of us know how to do is depersonalize, but to kind of disconnect from yourself this much, to give your overview, it can be exhausting. Sometimes I have found I've tried to reclaim some agency when I've thought, how much does this person genuinely need to know? How many of these things are actually necessary for this space? I think something Eva mentioned that is very interesting is around like details kind of constantly being outdated, constantly updating things. The NHS deals with so many systems, and it's like systems on systems on systems. It's a horrifying legacy mess of a kind of tech stack. And numerous times it's happened to friends of mine where everything's supposed to be changed, everything's supposed to be new, and suddenly something somehow is updated, and just everything is like it was before, and it's like, oh my God, it's a Tuesday, I don't have the energy for this. And I think I don't know if it necessarily gets easier. I think you become more adept at it over time. Um, and also, it's remember that you can bring advocates. Remember, you can bring people in who have your back, be that people who are assigned through a charity or through an organization, or they can be people like chosen family or friends. I went through something really kind of exhausting and protracted, and as a healthcare issue from a gender affirming kind of surgery gone wrong, like late last year, and it finally got resolved like maybe beginning of Q2 this year. And towards, I think, December, I was so destroyed by it that I needed my kind of chosen family member to completely take over my communication with the healthcare provider, because they were honestly exhausting. And like that support is there as well. Like your community is there for you. So that helps.
Thank you. Thank you so much for sharing, Coda. Saba in the chat box, and before we go to that, just we'd love to know what is one thing you've learned that you'll put into action following this session. That might be around allyship, it might be professional, community driven. We'd love to know. So please do drop those in the chat box. But just to come back to Saba's comment, Saba says, I'm hearing you, Coda, say it's exhausting, and knowing some of the conversations we've had, Eva, what would help you as individuals to support your mental health given current circumstances? As allies, we have a responsibility to check in and be there for you. What else can society do?
Oh, that's so nice. I think, as Coda's just said, it's absolutely exhausting. And, we find that navigating, especially shared care, we're almost like the middle person running in between, making sure that this person understands and we hand it over to that person, then we check back that they've actually done it, followed it through. And, allies, you can do that. You can check in just those little things as well, whether it's just making a phone call to a GP and saying, I'm phoning on behalf of Eva Echo, just want to make sure that the letter for an updated prescription from the private specialist has come through or it will be actioned. Can you let me know an ETA? Just little things like that, because otherwise, when you've got those sorts of admin tasks on the top of the admin tasks that we have every single day that all of us have, they can really mount up. And just giving us a few minutes, an hour where we can just do something else, we're not having to constantly chase. That can be huge in the long run because it means that we're not expending energy where we can really save it and use it on something else.
Yeah, that's such a great example of best practice from a professional perspective as well. How about you, Coda? What have you seen best practice professional wise?
Um, I think, yeah, I've been fortunate that I've had line managers who've been very, very supportive, and they've been able to shoulder a lot of emotional kind of like labor that I've been like, I cannot do this on my own right now. I'm just gonna vent. I'm gonna talk about how frustrating and exhausting things are. And I think being able to position yourself as someone who is capable of listening, not just willing, but also capable of listening and of hearing how heavy things are for someone else can be really important. I think some silly things, and maybe not super professional, but things like calling your GP. And I think it's because that little support looks quite different depending on the people who you have a relationship with, right? So it's about actively listening to what someone is talking about as a challenge for them, and then finding those innovative kind of quirky ways to help them. Something that would feel really special to me would be if someone told me, hey, by the way, like I had a conversation with my GP. I called him up to ask them about how they are with like trans things. I asked them specifically about like this and this thing. And they assured me that, or they had a thought about, or they had some resistance. So I'm going to speak. So I'm going to see like what's happening. But yeah, that's something that I'm like going through. Something else would be, I mean, I literally had my partner pick up my prescription from like for like um, uh, I call them my happy pills, my like SSRIs, because I was like, it's under my dead name. I can't do it. You know my dead name. You know all these things like this. These are my details. Can you just go and please take it? And he was like very, very loving and very sweet about it. But that's gonna look different for everyone. I
Yes.
see that we're in our key takeaways, and it's my turn.
We are. So just thank you both for sharing. And as I say, we have got the takeaways on the screen, but just yeah, thank you for sharing. I think that what you've both just said is it's thinking outside the box with how we help. But if you haven't got that, the least you can do is listen, and we can all do that. And then that goes such a long way. Coda, I will come over to you for your takeaways for the audience.
Super quickly, I think cultivating a sense of it as a trans person, if you're a queer person, trans person, kind of seeking and figuring out what the hell is it going to look like from here on out. I think cultivating some sense of agency is really important. This is inherently a journey where you don't have full control. So being able to kind of to focusing on the areas that you do is really helps. I think being like allowing yourself to to develop an action plan, possibly having people around you that can help you with that, it can be incredible. Acknowledging how burdensome the work is, and like it feels like genuine labor. So thinking about your well-being and focusing on taking care of you, be that through kind of immediate coping mechanisms, maybe slightly more longer term genuine well-being, as long as it's not actively damaging I mean, everything's fair play sometimes. And then the last one really is just like saving. And this is very much kind of geared towards trans people, kind of maybe, I guess, maybe a little bit selfishly, but yeah, saving whatever you can, because that is also going to contribute to that sense of agency and that feeling of, oh, I'm in control of, at least I'm in control of this.
Thank you so much. Eva?
Um, as I've already mentioned, if you're not happy, you are entitled to a second opinion. That every GP practice has a certain process in place to handle this sort of thing, even before it gets to a complaint at the, for the practice manager. So if you see a GP and you're not happy with the results, or you feel that they weren't listening, you can seek a second opinion at the same surgery as well. Also, something that not all trans people understand or realize is when it comes to gender dysphoria clinics, you can be on more than one waiting list. A lot of the time they will tell you can only be on one, but I'm actually on two at the moment, and you just have to promise that when you get to the top of one waiting list, you will phone up the other one and say, can you take me off that waiting list, please? It's due to the nature of how the NHS works when it comes to referrals to specialist services. And I actually found this out because when I found out that my first gender clinic had ridiculous waiting times, I phoned them up and asked what can I do about it, and they were the ones that told me that you can ask your GP to refer you to another gender clinic as well, citing that the first one that you've been referred to has a really long waiting time. And thirdly, pick your GP. When it comes to seeing someone, you're sometimes assigned a GP, but you can also pick another GP to speak to. The GP that I always speak to is not the one assigned to me, but she's lovely, so I always go back to her. But also, you can take someone else in with you as well. You can have almost like a chaperone. Remember that it's their place of work, it's their surgery, but it's your medical problem, so they're there to help you.
Thank you so much. This conversation has been so insightful, informative. Thank you for sharing so openly. As a cis person, I'm taking away how privileged I feel with that, and I just encourage others to just be more aware and just listen, because I think that some of the things you've tackled today, people just won't have heard. So thank you so much to our audience. These conversations are here for you to share. We're recording these for a reason. Please do share them with anyone you might think might benefit from listening, and keep these conversations going. It's really important. We appreciate your feedback. Please let us know how we can improve these sessions. You'll get an automatic survey come through afterwards. And finally, thank you for joining us at We Create Space. Stay tuned for more of our queer living webinars, our in-person events. We love bringing people together to learn, connect, and grow. And doing that with people like Coda and Eva is so fantastic. So thank you both so much, and thank you to our audience. Cheers, everyone.